All right, it's top of the hour and we have a lot to get through today, so I'll go ahead and get started. Welcome everybody. My name is Anthony Austin. I'm a global marketing manager here at Medix Biochemica. And today our webinar is entitled Know Your Tools, Hormonal Diagnostics for Fertility, PCOS, and Menopause. And like I said earlier, there's quite a bit to get through, so we'll go ahead and get started. First off, you'll notice that the chat function is disabled for today. However, the Q&A button is open and we do encourage you to submit any questions that you have. We will hold a Q&A session at the end of the webinar. I said earlier, we have quite a bit to get through. We'll probably run a little bit over time. I do apologize in advance, but I'd like to keep it going and not cut it off short so that we have the whole presentation available for you on the on-demand link. But we will get to as many questions as we can, and for all the questions that we don't get to and don't have time to answer live, we will follow up with you with an email after the webinar and get you all the answers that you need. I mentioned it, but the webinar is being recorded, and that's so that we can provide you with the on-demand link, and so that you can share with your friends or family or colleagues, however, everywhere you see fit for what they might be interested in. Welcome again to everybody, of course. We are Medix Biochemica, an international, independent, and industry-leading raw material supplier, especially for test manufacturers. This year, in 2025, we're celebrating 40 years in existence. In 1985, we started in Finland, where we were one of the first and key players on the scene to provide at scale, at quality monoclonal antibodies, especially for test manufacturers and especially for IVD industry. Like I said, we started in Finland, but since then we've grown quite a bit, especially in the last 5 or 6 years, to now have manufacturing sites not only in Finland, but also in Germany, France, some in the United States, as well as in China. And we've also expanded our portfolio quite a bit product-wise. So today we can offer many more of the same monoclonal antibodies that made us famous. But not only that, we also offer antigens, proteins, clinical enzymes, molecular diagnostic reagents, biospecimens, you name it, whatever it is, chances are we do that. We have expertise within our facilities for a wide range of applications. And it really is our vision as a company to be your first choice raw material supplier, should you be in the need for test manufacturing. And we hope that we can work with you to understand your needs and provide some solutions so that you can build quality in each and every one of your tests. So now to the fun stuff. We're excited to be joined today by Professor Terhi Piltonen from the University of Oulu, Finland. And she's a professor there in the Department of Obstetrics and Gynecology. And she'll walk you through some slides that discusses the importance and information around hormone diagnostics, especially as it relates to the areas of women's health and fertility. Then we will pass it over to Dr. Maria Voutilainen, who's a colleague of mine and a global product manager here at Medix Biochemica in charge of the hormones diagnostics portfolio. And she will talk you through some solutions that Medix Biochemica can provide in terms of antibodies, antigens, and biospecimens, should you be in the field of assay development for hormone tests. And with that, I will pass it over to you guys. I will stop sharing my screen, and then I will turn my video and audio off, and I'll hand it over to you guys.
There we go. Thank you, Anthony. Thank you, Maria. Does this look okay to you? Very good. So I take that as a yes. So let's go and talk about hormonal measures, and it is important that you do know your tools when you're assessing women for their gynecological health and fertility. And my name is Professor Terhi Piltonen, and I'm here in Oulu, quite far up in the north. So if we go on, and I'll introduce my disclosures. So these are they are here, and of course, Medix Biochemica has been invited me to talk to highlight. I'm the president of the AEPCOS Society currently, actually, and then also I'm working on contraception and other hormonal factors. So I'm happy to talk about this very important topic here today. So we are going to present, I'm going to talk about fertility, menopause, polycystic ovarian syndrome, and hypothalamic amenorrhea, and how these all conditions will kind of intertwine in your clinic and in your labs, and how is it important to segregate these conditions. There is a nominating factor for all of these. It is irregular menstrual cycles. And if you look into this diagram, you'll see that there are lots of overlapping traits in all of them. We'll go through all these and then come back and then summarize what you need to know. So of course, everything starts with the hypothalamus, the hypothalamic pituitary ovarian axis, the IHBO axis. You know that there is hypothalamus that is controlling the pituitary with the GnRH pulses. And then from the anterior pituitary, there are the gonadotropins, luteinizing hormone and follicle stimulating hormone that are now stimulating the ovary to work and make those follicles develop, and then the oocytes in it, and mature them every month so that the ovulation can occur, and then of course the pregnancy, enabling the pregnancy. And then if this axis is working really well and these hormones are produced from the ovaries, they will actually signal back, and they will have positive but also negative feedback loops, mostly negative, so that they will control their own secretion. And of course, as an outcome, the hormone factor, which is being in the granulosa cells, that is also, it has these theca cells around these granulosa cells. So LH is making sure that there is enough of androgens as a precursors for the estrogen synthesis. And in the end, the follicle stimulating hormone will now make sure that the androgens are turned into estrogens, and of course aromatase is here a very key player. And how do we see all of that? Of course, having on top of here the gonadotropin, hormones that are fluctuating. The ovarian cycle is going on, and of course the ovarian hormones are fluctuating as well. And the outcome, what we see, of course, is the menstrual cycle. And the menstrual cycle is something that we do need to understand to be able to kind of think, what is the axis, or where in the axis the problem lies. So the endometrium is a very crucial tissue. It's very, very unique. The endometrial lining that I have pointed out here as a green, it is a ovarian slave tissue. So the ovary is really controlling what happens in the endometrium during the menstrual cycle. And in average, the menstrual cycle is about 28 days. And then there is a big variance from women to women. And it can range from 21 to 35 days, and there should only be like a 7-day difference between different cycles for it still to be regular. But what is very, of course, obvious is that by these different cycles, it sheds every month about 5 days. And during women's lifetime, there is about 400 cycles, unless they are on some hormonal contraceptive that might give them amenorrhea. But also irregular cycles are very, very common, thinking that during these 400 cycles, there can be lots of different events in women's lives. So they are very common. And in fact, every fourth woman has experienced irregular cycles at some point during their lives. So what about the regulation? So then what we see is that the first day of the menstrual cycle, that is counted as the cycle day 1. And from that on, we start counting. So you can see it here down in the bottom, so day 1. So at this point, the pituitary now runs this so-called follicular phase, where the follicles are now starting to grow. They have already recruited for this particular cycle. There are several of them, and now they are pushed by the FSH that you can see that is rising here. So they are pushed forward. And then, of course, by the same time when they are pushed, there is more and more granulosa cells, and now they are secreting estrogens. And then they are going towards the mid time point of the menstrual cycle. And because of these high estrogen levels, there are now certain GnRH neurons that are actually now reacting to this high estrogen very positively. And usually during the follicle phase, usually the estrogen feeds back negatively. But now, just before the ovulation, these particular GnRH neurons, they are sensitive for the high estrogens, and now they are doing positive feedback, these estrogens, and they are causing the LH peak, which now launches the ovulation. And this occurs usually around the day 14, and this is the initiation point when also the corpus luteum for the resting granulosa cells, they are luteinized, and now the corpus luteum is formed, and now the secretory phase of the endometrial cycle can start. So here, you'll see the corpus luteum that's formed, that's marked here, and the progesterone is secreted as shown by the red arrow. So now at this time of the menstrual cycle, the progesterone levels are the highest. And after about 7 days of this secretory phase, the endometrium goes a specific transition. So it actually it differentiates it opens the window of implantation, where that is the particular time, about 3 days, where the embryo can attach, and this is very crucial time point, of course. But if there is no pregnancy, the corpus luteum is then collapsed, and the progesterone levels, of course, they are plunged, and that is a signal for the endometrium to now start breaking off and starting a new cycle. So that's it. That's the endometrial cycle. Now, what sort of irregularities there can be for the menstrual cycle? So the cycles can be short, they can be long, they can be irregular, so that they come whenever. They can be heavy bleeding. That's also considered irregular cycle. And then also cycles where there is no bleeding, so absence, so amenorrhea. That's cool. That's also considered irregular cycles. And then intermittent bleeding. That means that there is a spotting during the cycle, which, it's kind of there is like a cycle, but there is also bleeding now and then. And of course, there are some tools that we can use quite easily to track, whether the cycle is irregular or not. And of course, these applications there are many of them freely available. Many of the women use these, and they are so excellent to use to track these cycle irregularities when they are in your office. And of course, there are also visual tools to help detect how heavy, for example, the menstrual bleeding is, so that you can have a little bit of an idea how thick the endometrium must have been before it shed it off. Now, when you're starting to track the problem, it is very important to think, what am I looking for? What is the thing that I'm really looking for? Am I looking, in what stages? Am I looking for gonadotropins? Am I looking steroid hormone secretion? Or am I looking other factors that actually might be involved outside the axis, although the axis, of course, is very reactive to some of these other hormonal changes. So gonadotropin levels, usually it's good to measure them early in the cycle, because usually it tells that if they are elevated, there is a signal, there is not enough estrogen to keep them down, and they are now kind of orchestrated to push. They are high, and they are pushing the ovary to work better. So usually that's the signal when they are very high. And now, on the other hand, if the signaling or the axis is very, it's kind of pressured or hindered by something, they are down. And the most perfect time to measure them is actually during the early cycle, unless we want to detect ovulation. Of course, here you'll see the LH peak, and that is the urinary samples that we do the ovulation test. Usually, the women take them at home. It's quite rare that we do it in the lab. What about the steroid hormones? That's the second, and that's the ovarian level, then, where we are talking about next. And again, preferably to be able to kind of segregate from these waves that are during ovulation, and then on the kind of a mid of the secretory phase. Usually the estrogens, for example, they are good to measure early in the cycle. And on the other hand, progesterone, if you are looking for whether the woman has ovulated, you should measure it about 7 days after ovulation, just to see that, that's the most likelihood of the time points where the progesterone levels are high. And of course, there are other factors like thyroid hormones, prolactin, ferritin, etc. So preferably you should monitor them early in the morning, in the early cycle, menstrual cycle, as that might, give you opportunity to measure also other hormones. But in some of the cases, it really doesn't matter. For example, thyroid hormone, it doesn't clinically matter at what time point during the menstrual cycle you measure them. But still, I think it's good to remind that this is the perfect time point early in the cycle to measure all of these hormones, unless you need particularly something else. Now, what about then fertilities? If we are looking into fertility assessments, of course, we need to come into minds that normal fertility status is called if the pregnancy is achieved in 12 months. So if it exceeds 12 months, then we're talking about infertility. But it is very age dependent, and you'll see from this figure that the likelihood of getting pregnant, it really varies, so it really declines when the ovaries are aging. So you need to consider that you wouldn't consider a woman that is 39, it is unlikely that she'll conceive in 12 months, but it doesn't really matter because we still need to help them, because now they're closing their fertility window. So we need to try to start assessing whether there are other reasons than just for their age, for becoming that is hindering from them to become pregnant. But you need to consider that age of course is a very crucial matter, and age dependent. And of course, there are other factors like BMI and other health factors. If you have, for example, chronic bowel disease, or like inflammatory bowel disease, or some other some other chronic condition, they can also impair your fertility. So it is important to look at the couples as a whole. But ovarian aging is something that is there. The number of follicles, of course, decrease in the ovary over time, and that is not all. Also, the quality of the oocytes decrease. So it's not just the number; it's also the quality. And of course, the likelihood of pregnancy, and the cycles, they change over the time, and there are some hints that you can actually pick up from your patient's history when you are trying to kind of figure out where she is in this slope. And what is worth noting is that you'll see that there is a text here, declining fertility, that is between the 30 and 40 years. Of course, the fertility decline actually starts even before 30, but it definitely starts, showing after the age of 30. But the irregular cycles, they don't show up until quite late regarding fertility. If there's a healthy woman without any other irregular cycles, actually come quite late. So the fertility has declined for over 10 years until the cycles become irregular. So here, cycle irregularity, they can tell you something else, but if you wait for irregular cycles, that might be already too late. So you need to kind of go back, and you have other measures than irregular cycles to be able to detect what is the fertility or ovarian status for the particular woman. Of course, now, so here we have an ovary, and from the left, you'll see an ovary that has these beautiful antral follicles and small little follicles that are developing follicles that are just under the cortex. And then on the right, you have a ovary that is exhausted. It doesn't have any follicles left. And then there is a magnification of a follicle with the granulosa cells here beautifully marked. So these are the ones that are producing estrogens and also anti-Mullerian hormone. I want you to remember this particular hormone specifically. We are going to talk about it a lot during this presentation. So anti-Mullerian hormone is here. And then there are theca cells that they're a little bit difficult to see, and they are producing androgens. So altogether, the number of follicles, they do decrease over time, and this actually does affect the AMH levels, estrogen levels, but also the gonadotrophin, because now, as I mentioned earlier, if there is a low estradiol level that doesn't have the kind of a normal feedback, it's low, so it can't push down these gonadotrophins. This is a message for the pituitary to start a little bit of a rushing the ovary to produce more hormones. And that, what the ovary actually can do for quite some time, it sustains the estrogen levels for quite some time by elevating the gonadotrophin levels. But on the background, AMH goes down. Androgen levels also go down, not so dramatically as estrogens, but they do decrease over time. Um, All of this, as I said, is reflected by the decrease in anti-Mullerian hormone, and then these time differences between the estradiol that is decreasing later than estrogen, than AMH, because estrogen is kind of kept up. It has to stay up for quite some time because it is so important for the whole female body. So there are mechanisms to keep it up, and that's the elevated FSH that we can also measure. But here, these are the measures. So you'll see the estradiol, it stays up, even though I think for this figure, FSH could go a little bit even higher. But as you'll see here, it's a 10 international units per liter. So it's already a little bit elevated because the normal range is about from 3 to 5. So you can see that here it's already elevated by the time of 44. So it has already started to push the ovary to keep this estradiol level high. And then you'll see that the AMH levels is still plunging. And then after menopause, when we have lost the reserve from the ovary, the FSH starts, there isn't no feedback. There is no kind of a break for the FSH. So it can freely go up, and it actually does. And it's as high as about 80 international units per liter. And then the difference between FSH and LH is that the LH is actually not reacting into this. It's a little bit slow. It doesn't really react on all of this so well than FSH. So LH is usually not that good to pick up the ovarian reserve as FSH, and everybody who are working on this topic, they know that LH is not a marker of ovarian reserve. It's not a very good one. It does correlate with the AMH, but it to some extent, but it's not very good on sensing this very key time point in women's life when we are going towards menopause. Now, you need to also understand the physiology behind, for example, cycle length. So I have just presented here 3 different patients. So patient 1 has a cycle length of 28 days. So this, we assume that it's a normal ovarian reserve and everything comes on a timely manner. The LHP, we assume, is here around the day 14 that I have marked here. That is, and then consequently they would have a 14-day secretory phase, where the corpus luteum is alive, and kind of the pregnancy is can happen around the days between 20 to 22, around that time. Then we have patient 2. The cycle length is only 22 days, but it's still normal cycle, right? Because the cycle varies from 21 to 35, as I mentioned. So it's still considered normal, but the physiology is completely different. So here, the first 7 days, so the follicles need to mature very, very quickly. So you can already see that something is pushing the cycle very fast to move on, and the ovulation now already occurs at day 7, and then you have this 2-week time period again for the corpus luteum to be alive. So already now you can see that, okay, I can see that the follicle phase is very short, and probably that's due to higher FSH levels that is pushing the ovary to work better, but it's also making the ovary work faster, or the follicles mature faster. And of course, for a fertility aspect, it's not very good, right? Okay, and then we have another one. So here again, we have a regular cycle, it's 35 days. And now we'll see that, oh goodness, it's very, very long, this follicle phase. Most likely the ovulation comes at day 21. And still, this is a normal cycle, but somehow these follicles, they're kind of thinking what to do. They're growing very slow. So you are also thinking that, there is something that is, having these follicles to arrest a bit, kind of being slow, and that might be AMH that is hindering the growth. And you kind of assume that this patient most likely has higher FSH levels. It is unlikely that it's, or of course it might be that there is already like an ovarian aging factor here as well, and it might be that there is no ovulation here either. But I think, depending on the age, if this is a fertile age women, I think my guess would be more like this is a kind of like a almost like a polycystic ovarian syndrome. At least I assume that there is a high reserve of ovarian follicles, and I'm guessing that there is higher AMH values, because the AMH is now keeping these follicles from progressing very fast. But on the other hand, if there is this situation where the follicles are very slowly progressing, it might also lead into the case where the ovulation is not very optimal, or it can't even happen. So this is another end of the spectrum. So these extremes are not very good for fertility. So we're really aiming to see these 28-day cycles. Now, when you're doing fertility assessments in women, of course, you need to pay attention on the age, BMI, changes in weight. Sometimes changes in weight are even more important than the absolute BMI, so you need to also look for into this. Menstrual cycle length, as we just said, it's very important to understand that. Menarche, parity, family history of menopause, or family history altogether. Are there infertility in the family? Medical history, including all these medications, obstetrical history, of course, if there are any problems that occurred during previous pregnancies. Medication, supplements, time to pregnancy is very important. So, and then you're looking into these cycle-related factors. But what can also help you now are the other assessments that you need to do. So, of course, you'll carry on with the gynecological examination. You do ultrasonography. We need to image the uterus, the ovaries. You'll see the idea, what's the reserve, what you can estimate. The tubes, the peritoneum. You look into tubal patterns, see if there is a risk for occlusions. But serum AMH is, of course, is quite central key now when we are looking into serum measurements, because now, as we talked, the low AMH levels may have an implication of lower ovarian reserve. If it's normal level, then you might be able to or kind of think about other reasons behind the infertility, for example, endometriosis, or is there a male factor involved actually? Or then high, you're considering, is this PCOS? And then you start looking for the PCOS typical traits. Thyroid hormone function, that's very important when you're assessing for infertility. So you measure TSH and T4. Whether you need to do antibodies, you need to think about, the overall picture. Prolactin, of course, this is very important. It doesn't really matter what is your assay, but prolactin is noted, by its how is it produced. It's very sensitive for errors, so you need to maybe do it twice just to make sure that it's good. Especially if you, after the first one, if there is a abnormal value, you need to usually rerun it and make sure that everything is going by the book, because there are lots of factors, for example, smoking or intercourse, that can affect prolactin levels. It's very sensitive for errors. And then consider LH and FSH. Of course, you need to think about the whole picture, whether you need to look into these, are they in the normal level? And then consider when you measure them. And ferritin, is there heavy menstrual bleedings? Are you thinking that, there is an iron deficiency there? Is there currently at the same time also inflammation? Do I need to look into the inflammatory factors just to make sure if my ferritin is kind of if there is a heavy menstrual bleeding and the ferritin is low, is normal? I think thinking about making sure that you don't take the measurement when there is when the patient has a flu, etc., because the inflammation is having ferritin levels to go falsely high. So you need to also consider this, and then other markers as you consider, for example, celiac disease markers, etc. So after fertility, then, now you've kind of picked out, your markers and your measurements for the infertility assessments. And now you're kind of thinking another end of the spectrum. You're now thinking, is this early menopause or is this menopause? So now we are going into ovarian reserve. And here, of course, if you have infertility patient with you, it has to be reminded that about 1% of the women actually experience menopause early in life, so they have premature ovarian insufficiency, so their ovary has exhausted too early. And there are also cases where the about 5 to 10% of the women also they have early menopause, meaning that their fertility has declined about 10 years earlier, which means that if their menopause is at age 44, their fertility is poor at age 34. So this is something to consider. And of course, family history in that sense is very, very important to think about, because these are usually genetic traits. Smoking, of course, makes menopause about 2 years earlier, but otherwise there's lots of genetics involved. So if there is early menopause history, you should very much be aware that this might also affect your patient. And then, of course, here there is the I've marked here the average menopausal age at 51, which means that the fertility is already 10 years earlier, quite poor. So at age 41, and of course, this we know. So what about the menopause altogether? As I said, the age at menopause, even if it's on the normal range between 45 and 55, it really varies, and the history is important. So usually the symptoms, they are related to estrogen deficiency, hot flashes, joint pain, sleep problems, sexual dysfunctions, dry skin, eyes, and vagina. So these are very, very typical symptoms, and you should ask about them, and they are quite common, and especially the hot flashes, and then the hot flashes, and the sleeping problems are the very kind of like a central symptoms for menopause when you, for example, thinking about HRT initiation. But what is the problem is that, of course, there is no ovulations. There haven't been probably ovulations for quite some time prior menopause, and of course that's related to fertility issues. And as there is no corpus luteum there, now there starts to be irregular menses, because the progesterone is the factor that is now restricting the estrogen effects on the endometrium. So progesterone makes sure that the endometrium doesn't grow too much, and it makes this shedding, as I said, that the progesterone, depriving the progesterone from the endometrium, now launches the menstrual cycle. So now when there is no corpus luteum, there is no progesterone, the endometrium is very progesterone deficient, it can progress and proliferate very long, and that's why the menstruations can be very irregular and very heavy. And usually, as I said, the first phase is that the cycles get shorter. So first they come a little bit irregular, then they come shorter, and then in the end they are absent completely. And what is interesting is that these symptoms can start very like several years earlier before the menopause occurs. So about 10 years earlier, there might be some of these symptoms. And now it's very important, as for diagnostics, to be able to segregate menopause from other factors that can be here involved with these symptoms that are actually quite common, and sometimes also a bit unspecific. So other factors that you should be able to pick from the background is, of course, mental distress, thyroid problems, or other conditions like obesity, related sleep apnea, diabetes, etc. So there are other conditions that have to be ruled out and thought about, of course, when you're assessing this. But going specifically to the menopause diagnostics, of course, again, you need some of these laboratory values sometimes to kind of confirm your idea. And here I think the field is moving towards AMH. We are still using, for example, at least in Finland, to reimburse some of these HRT products, you would need to have FSH measured. So AMH starts to be quite low when the AMH value starts to go beyond below 1 nanogram per mil. We know that reserve is already low, so we know that we are approaching to the time when the reserve is getting low and menopause is getting nearer. And then as a result, you will see probably a little bit heightened FSH values. About from 7 to 10, you see that it starts, the baseline starts rising. And this is the same figure that I showed you earlier. And then in the end, when just before the ovary has already started to, so the follicles are kind of gone in the ultrasound, but there are still some of these small little follicles that you can't probably see, but they're still producing AMH and estrogen. So there is a little bit of estrogen still involved. So the FSH levels are around 30, and then you can see that, okay, this ovary is already beyond fertility. There are no working follicles. There might be a little bit of estrogen to keep the FSH still not on the, like uncontrolled, but still we are now approaching to menopause, and this can already be said that we are talking about menopausal ranges of FSH if we are going beyond 30 international units per liter. And then here you'll see from the figure again that when there is uncontrolled, there is no estrogen at all, the FSH will go as high as 80, and then later on it will go down a bit still, but the highest peak is about 80 international units per mil. And then again, LH is a little bit slow in this process, so it's not very good marker. So it doesn't have really a diagnostic role here. And then, of course, you need to consider that if there are some symptoms, but still you're a little bit, kind of a hesitant what's going on, you need to remember that some of these medications, hormonal medications that will have sex steroid hormones in them, like combined oral contraceptives, they'll push down the own ovarian steroid production, but they will still feed back negatively to the pituitary and keep these gonadotropins low. So in that way, you might need to sometimes come off from the pill just to see, or then you can just have like another assessment for AMH that is going down in the background to see whether that's completely abolished to kind of detect the menopausal status. So here AMH is a little bit better marker than LH, or definitely than LH, but also better than FSH. But in the later, if you want to get good diagnostics, what is the estrogen status, etc., you would probably also consider measuring FSH. But of course, the symptoms are also very indicative. But here, just to remind you again on the picture on the left, that there are different phenotypes, the ovarian reserve phenotypes in women, and it really depends where you are in what spectrum. Are you the one with the very low reserve altogether from the beginning, or with the little bit higher reserve, like women with polycystic ovarian syndrome, where the ovary carries on, the follicles will carry a little bit longer, and the AMH levels preserve a little bit longer. But AMH it's a quite good marker to kind of distinguish between these. But you need to also look into the whole picture, of course. So after going into menopause, let's still talk about the ovarian reserve. And here now we have polycystic ovarian syndrome in our hands, and why is it really important to distinguish here with the irregular cycles and ovarian reserve is that it's very, very common. It's about 1/6 of all of the women, and I encourage you to read this recent review that we just published in the Nature Review Disease Primers. So PCOS, according to the last international PCOS guideline, we are endorsing the Rotterdam Consensus, where 3 of these cardinal findings or symptoms are present. So oligoamenorrhea, hyperandrogenism, and polycystic ovarian morphology. And it's good to remind you just now when we are talking about diagnostics and laboratory values is that 80% of the women are actually hyperandrogenic, but you probably need also to use some of these laboratory testing to make sure that whether they are hyperandrogenic or not. Polycystic ovary syndrome, however, is not only about ovary and the ovarian reserve, and we know nowadays that it's a common comorbid or multimorbid condition with the metabolic, psychological, and reproductive outcomes. So I've written you all. You can read from here what are the most common comorbidities, and we should be able to also use some of the diagnostics and laboratory values to really look into their metabolic profile and of course on the reproductive profile as well. But I think the metabolic one is the that we are very often kind of overlooking, and that is something that we would need to really precise our diagnostics and see, do they have elevated blood lipid values, and what is the blood pressure, and so on. So I think we really need to be aware of this risk. Now, hypoandrogenic phenotype actually it seems to be also associated with the high comorbidity profile, and this is again important to when you are looking into the diagnostics to be able to see whether this phenotype is hypoandrogenic or not. This is the guideline. I encourage you to read it. So it's been published in all these different journals. And if you want to look into the original publication, you can Google PCOS and guideline and Monash. You'll see this is now put on the Monash web pages. And I think it's a very, very good read. It has also summary that is easy to kind of condense your information. So this is the diagnostic algorithm. It's not the same. It's kind of a little bit shortened from the one that is on those web pages, but I have summarized it here. So first of all, in the first line, when you're looking for diagnostics, you do assessment of clinical hyperandrogenism. That means Ferriman-Galloway score that is right here on the right side. So you score these 9 different skin areas for hyperandrogenic male type hair growth, and then you look for irregular cycles. And already if you have these 2 traits, you don't need to move forward. You can already think that, yes, I think this is PCOS, but of course you still need to exclude some of the other things. So you need to exclude 17 hydroxyprogesterone excess there, and then you need to look for prolactin, or is there a hyperprolactinemia, is there thyroid function problem. So you need to do some of these exclusion or differentiation diagnostics as well, and it's very important. But if everything is fine and you don't find anything, you can make the diagnostics already by then. The second stage is that if there is only irregular cycles, now you look into testing biochemical hyperandrogenism, and we'll go and look into that later. But you can do testosterone, free androgen index. You can also measure androstenedione. So these are endorsed, and also DHEAS. But I think DHEAS is not that maybe accurate. I think in our hands, we are going to have some publications coming out. So I think androstenedione is actually a quite good competitor for the testosterone measurements as well. So that could also be used. But I encourage you also to measure SHBG, the sex hormone binding globulin, and count the free androgen index, because I think that can also reveal many of these hyperandrogenic cases. So you look for biochemical hyperandrogenism if you only have irregular cycles. And if you have only clinical hyperandrogenism, then you can also look into the polycystic ovarian morphology by the higher AMH levels or by ultrasonography. So these are the options, and you need 2 out of 3 to be able to make the diagnosis. And I would like to highlight the serum AMH is now the last one to come to the diagnostic tool pack. So you can use as a surrogate for ultrasonography, because that's sometimes the availability of that is not that good. What do you need to remember from adolescence is that you do not use the ovarian criteria for the adolescents. So this should not be used 8 years post-menarche. And also you have to remember by irregular cycles that the cycles can be irregular about 3 years after menarche, because the axis is immature. So it takes time for it to mature. So you need to wait a bit. So you have to be a little bit careful if you have very young women, and then please do not use the ovarian criteria 8 years post-menarche. But after that, you can start using also the ultrasonography or AMH measures. But if we think about altogether all these 3 factors, and we have looked, this is a population-based data where about over 1,000 women that were examined for the different diagnostic assessments, and thinking about from the androgens, what are accurate, or what are the tools that we can actually point out who would have PCOS. So here, the Ferriman-Galloway score, of course, if you are hirsute, it's very likely. So it had the highest likelihood to associate with PCOS. PCOS. But second line, we already have, it's about, threefold risk when we are using free androgen index, so testosterone divided by SHBG times 100. So if the free androgen index is quite sensitive, but also total testosterone is not as good, but it's quite close. And then BMI, it's a little bit insignificant, even though we know that it associates with the condition, but it can be also without the condition, so it's not that sensitive. And then insulin and LH, they are to some extent, they are there. We know that they are intertwined in this very common syndrome. But then FSH, you cannot do any differential diagnostics with AMH on PCOS. And this is just to highlight that these androgen levels or these androgen manifestations and measures, they are quite key targets for diagnosing PCOS or identify these women. And this is from the guideline. These are the recommendations. So as you see here, we have highlighted that you can measure testosterone, you can measure free androgen index. So they are now first line. Of course, the data is not, the recommendation is very high, but as you see, we need more stringent data to produce from here. And I'm hoping that in the near future, we get this. Second line, we have androstenedione and then DHEAS. Again, the recommendation is not that strong, and the evidence is only one kind of like a first level. And then we recommend also to use first line, the LCMS for these different androgens. So immunoassays can also be used, but it has to be a very good lab to have these assays. But of course, if as women have very low levels of these androgens, so they might be not that sensitive. So you have to be a little bit careful here. But assays different assays can be used, but LCMS is the first line, and it's been highlighted here in this recommendation slide. But when we were looking into these different androgens in our population-based data, you'll see that it's quite interesting that you can actually pick these women up with the androgens, in the fact that only when we are looking for a threshold of 2 nanomoles per liter, from our data set, actually already 1.8 nanomoles per liter would be a good threshold. But this is a national threshold of 2 in Finland. So we have been looking this from our data set. You'll see that from the controls who do not have PCOS, about 1% will now have testosterone levels over 2, whereas already 21% of the women with PCOS have testosterone levels over 2. And then if we are looking for free androgen index, that in our hands, of course, depends on the lab, because the SHBG can vary a bit depending on the assay that you're using. But in our hands, the free androgen index over around 5 is indicative of hyperandrogenism. Here again, 15% of the women will experience free androgen index over 15. So we know that women with PCOS, they are more likely to have some sort of hyperandrogenic manifestations. And in our hands, in this particular data set, about 80% of the women with PCOS had some androgens, high testosterone, androstenedione, free androgen index, etc. So it's very, very indicative. But how, so I'm just going to show here a little bit about the androstenedione, and testosterone. So here are the measures what we have from our previous study, and you'll see that quite nicely it shows that testosterone, the average was about 2 in this study, and it didn't really, in our study, it didn't really matter. Of course, it went down a bit for women over 30 testosterone, and then here androstenedione, the average was about 14 for the younger women, and then about 12 for the older women with PCOS. And then if we are looking for our other data set, this is a Nordic data set when we have pooled different studies. So here you'll see that for PCOS women, this 2 was a little bit too high level for testosterone. So that's why we are using a little bit lower values, or I think the women would benefit from a little bit lower values clinically for the testosterone. And then for the free androgen index, it was actually quite good. So already several women were over this free androgen index index level of 5. And then for the androstenedione was actually quite good because most of the women with PCOS had higher androstenedione levels. So you'll see that it's a combination of different androgen excess markers to be able to identify all your patients with the hyperandrogenism. So then when we move into ovarian reserve, this is the polycystic ovarian morphology on right and the normal ovary on the left. And these are not cysts. So you have to remember these are not, even though it's a polycystic ovary syndrome and we are about to change the name or just keep the acronym quite soon, it's on the process. So they are not cysts, they are little small follicles. And this is the findings for PCOS, that they are stagnated in the ovary. AMH is keeping them there. The FSH is kind of down, and it's kind of underworking, and it's not pushing these follicles to move forward. So they're stagnating and kind of stuck in the ovary, and ovulations are not occurring, and that's why the morphology looks like this. So AMH, it has 3 roles. So it's produced from the granulosa cells, and the normal values are around 1 to 3 between that. And then over that, we can already see that there is a quite high number of small antral follicles in the ovary when we go towards 4 nanograms per mil. And the job what the AMH is doing, it's actually hindering the small follicles that are not gonadotrophin dependent. It's kind of a stack there. It makes sure that the reserve is not, that it's not kind of recruited too much or too early. So it makes sure it's kind of like a door that keeps the early small follicles there, and also make sure that the FSH is not hitting the follicles too hard, so it's not pushing the follicles too fast to mature. And then the third role is that it also hinders the aromatase activity, so it makes sure that the estrogen androgen balance is equal, so that the androgens are not turned too fast to become estrogen. So on the other hand, if you have very high AMH levels, the original follicle pool is kind of a stuck. FSH is not working that well, and on the other hand, the aromatase is making sure that, or kind of keeping the steroid profile a little bit more on the androgenic side, and that's polycystic ovary syndrome, right? And of course, there is metabolic factors, insulin, etc., that are also working in this system. But we have actually looked into AMH diagnostics in PCOS quite stringently, and we know that the AMH levels correlate really well with the antral follicle count. The levels are about 2 to 3-fold higher in PCOS. And then we have tested for a diagnostic threshold of 3.2 nanograms per mil, and we have shown that it has very high specificity and sensitivity to detect polycystic ovarian morphology, not the syndrome itself, but polycystic ovarian syndrome, the ovarian morphology. And this has been replicated. This is a study that we have replicated from a Netherlands study made in Netherlands in Joop Laven's group. And then we do have to remember that AMH levels, they do decline also in women with PCOS. Although, as you see, this is a very old study from our team. So the levels actually tend to keep higher, and that way you can also use the AMH as a PCOM diagnostic tool quite late in the women. But again, there are some issues that you need to consider when you are measuring AMH. There are several factors are affecting AMH levels, and of course, age is one of them. We have already talked about this from several occasions. And then body mass index makes the levels a little bit lower. Caucasians have higher levels than, for example, Asians, Hispanic, or Afro-Americans. Menstrual cycle has a little bit of a change, but it's not clinically significant. We're about to publish that. Pregnancy makes AMH levels lower. Hormonal contraceptives, that's something that we need to remember, because this is very important when you're doing diagnostics, that you know whether there are OCPs that are used that are kind of masking the situation, but they can decrease AMH levels from about 10% to about 30 to almost 40%. And then of course ovarian surgery. So all of this needs to be taken into consideration when you are measuring AMH. And then for women with PCOS, you also need to remember that this is a lifelong condition. You can use a retrospective history, but then you also need to consider that the women start gaining regular cycles because the ovarian reserve is kind of getting normal towards the age of around 40. So they will start gaining regular cycles around the age of 35, and they will lose this ultrasonography appearance of the ovarian morphology. And there, I think AMH measurements becomes very handy, because I think it stays more kind of a significant longer than the antral follicle count. So I think that will be beneficial for the women. But sometimes it's very difficult to make any longer the diagnostic, so you need to use also some of the history, what was early on, how the cycles went. Hirsutism and the hyperandrogenism, that's a trait that seems to be persisting longer. And of course, the women, when they're aging, they will also get more spontaneous cycles, and of course, probably spontaneous pregnancies. And you need to make sure whether they want to also conceive. And if they do not, you need to remember to put them on the contraceptives. So finally, I'm going to talk a little bit about hypothalamic amenorrhea, because sometimes this could also be mixed with PCOS. And the fact is that, the ovarian axis, and on the other hand, the hypothalamic pituitary adrenal axis, they are very much intertwined. And if there is lots of stress in the life, the adrenal hormones, especially cortisol, is now able to kind of push back the ovarian, the HPO axis in a certain levels, in all different levels, and kind of cause blockage of this axis. So there can be different stress factors like mental stress, physical stress like dieting or exercise, and then pushing down this axis will now lead into low estrogen levels, irregular absence cycles, fatigue, low bone mineral density, etc. And because these patients are often young with a good ovarian reserve, the ovaries might kind of have PCOM looking situation. And then where there are irregular cycles, now we start thinking that maybe these women have polycystic ovarian syndrome. And it's not very, it might be that they have these conditions overlapping, but still you need to consider the differential diagnostics. And what is different between hypothalamic amenorrhea and PCOS is that both of them, they might have amenorrhea, so long cycles or no cycles at all. Well, here, cyst, they are small little antral follicles. So the ovarian reserve is good because many of the cases, these women are young and they have good ovarian reserve. So they make these PCOM diagnostics, and now they also fulfill the diagnostics of irregular cycles. So basically, they could be diagnosed with PCOS, although the underlying cause is something else, because they are not hyperandrogenic. And this is something that you might want to look into. There might be loss of hair because of the different reasons, the poor nutrition, for example, or stress, and cortisol, because in hypothalamic amenorrhea, and due to hyperandrogenism in polycystic ovarian syndrome. Estrogen, now this is crucial. Estrogen is low. Usually it is low with hypothalamic amenorrhea, whereas in PCOS it's usually normal. It's rarely high. Sometimes if there's lots of obesity, it's high, but usually it's normal. LH is now low in hypothalamic amenorrhea because now the stress factors have put the axis down. So here now the gonadotrophins becomes very important as part of this diagnostics. And in PCOS, the LH levels are usually, they're high, and the higher the AMH, the higher the LH. And we have some of these new data sets where when they're looking into that, AMH could actually promote LH secretion in the brain. And then the ratio is now low, the LH FSH ratio in AHA, and in PCOS it's actually high. And then bleeding with the progesterone, as there is very few estrogen to grow the endometrium in HA, so there are no bleeding pattern or bleeding after you induce progesterone and you retrieve it, whereas in PCOS usually you get some sort of a bleeding profile. Uterine lining is thin in HA, and in PCOS it's usually normal or sometimes it can be thicker if there is a very long proliferation. But actually, I don't see very high endometrial lining in PCOS, but it can actually vary. And then again, the androgens, they are low in HA and high in PCOS. So these are the different characteristics between the HA and PCOS. And now we go for a summary. I thank you for your patience here, and you've been listening really well. But let's go through the summary one more time to get everything together. So these are the different factors that we've been now today looking into, and there's lots of overlap, and you need to look into all these different factors and utilize your clinical knowledge and all these clinical parameters, but also laboratory values do really help here. They are a tool in your tool pack that you need to know how to use, and they can be very helpful. And this is the summary when you want to segregate between infertility, menopause, PCOS, and HA. So I've gathered you a table. These slides will be shortly shared with you, so you can take a look at them on your own time and make sure that you know your diagnostics and remember what to measure when. And then I think what we can summarize is that gynecological symptoms and irregular cycles are very common. There are many features that will overlap, and these really warrant a good diagnostic workup, and underlying conditions are very important to identify. Now, serum measurements can be very helpful for the diagnostics. AMH is a good marker for ovarian reserve, and it can also be now officially used as part of PCOS diagnostics. Gonatrophins are very helpful. Estrogens and progesterone measurements, they do support your clinical notions, and then you need to also take into consideration prolactin, TSH, ferritin if you're looking for different diagnostic factors, for example, concerning infertility or menopausal symptoms or PCOS. So they're also very helpful. And then think what you measure and when. It's very important. And then pitfalls, know your measures, know your tools, and know how they behave in different assays. And of course, then thinking about for example, COCs can mask different things. So you need to consider medications as well. So I thank you again for your attention, and I stop here.
All right, here we go. Thank you very much, Terhi, for the very interesting introduction to hormone diagnostics and all the great information. So thank you everyone from my behalf as well for joining the webinar. My name is Voutilainen, and I'm the Global Product Manager for the hormone clinical area here at Medix Biochemica. But let's get started here. So Medix Biochemica has decades of experience in the antibody manufacturing and IVD field, which contributes to our reputation as a reliable and trusted partner for providing raw materials for IVD assays. Our long history is reflected in the consistent quality of our products, including minimal lot-to-lot variation, and we are also ISO 13485 certified globally. We are equipped to meet varying production needs with scalable capabilities that allow for batch sizes up to tens of grams and annual output into kilogram range. Delivery reliability is one of the key priorities for us, and we also work closely with our customers to support the development of new products and to stay informed about emerging needs in different clinical areas. This includes co-development of materials and generation of application data across different testing platforms. And our portfolio is built through both internal development and also through acquisitions. And currently it includes more than 5,000 products to support assay development. As the over 5,000 products would suggest already, we supply a wide range of items across various clinical areas. And this includes antibodies, antigens, biospecimens, and more recently also stabilizers and blockers, meaning that we offer the full solution for any assay development purposes. Here you can see some of the clinical areas that we currently support. But of course, today we will focus on hormones and in particular the reproductive and women's health. As Terhi already really nicely discussed, hormone levels, especially reproductive hormones like FSH, LH, AMH, estradiol, and progesterone, are measured for a variety of reasons. Even though it's the same set of hormones, the clinical questions can vary. In fertility assessments, they help evaluate ovarian reserve, cycle timing, and in PCOS, they are used to identify hormonal imbalance. And in menopause, they reflect, for example, the natural decline in estrogen levels. So it's really all about interpreting the same hormones in different clinical contexts. And because these hormones are used across so many indications, it is essential that the assays that are used for measuring them are reliable. And that reliability depends heavily also on the quality of the antibodies used, since they directly affect sensitivity, specificity, and consistency. So high-quality antibodies play a part in ensuring accurate and trusted results. Our hormone portfolio at Medix Biochemica is very extensive, with close to 300 products available. It includes not only antibodies, but also a wide range of recombinant and native antigens, conjugates, and biospecimens to support hormone assay development. To help navigate the portfolio, we can group the offering into key categories, which are reproductive and fertility hormones, but then also steroid and adrenal markers, thyroid function, and growth and metabolic regulators. And today we have focused more specifically on the reproductive health area, obviously, but it's worth noting that our portfolio extends well beyond that. And these other categories also play a significant role in supporting a broad range of diagnostic needs. So as mentioned, we have a very wide range of different antibodies available, and I have listed here only few ones. But for all our monoclonal antibodies, we offer multiple options that also work as pairs for detection. And we also provide pair recommendations for all our analytes, which can be, for example, viewed in detail from our website under each product. For example, for the anti-Mullerian hormone AMH that Terhi also discussed in length during her part, we currently have 5 monoclonal antibodies available with specific pair recommendations for different applications, which is based on our in-house testing. We have also evaluated AMH detection using several assay formats, chemiluminescence immunoassay, lateral flow, and fluoroimmunoassay, and these have been done with clinical samples. So when using the antibody pair recommended, the results showed excellent correlation with those obtained using the established reference method. And this gives a clear picture of how antibodies perform under real-life conditions, and also support the confidence in their reliability across different platforms, and how the pair recommendations can be taken into consideration with different assay formats. And now to this slide that I already accidentally jumped to. So a brief update on something that's upcoming. So we are preparing now to launch new products to support assessing preeclampsia, specifically antibodies for PLGF and SFLT1. So as a very brief introductory background, preeclampsia is of course a very serious pregnancy-related condition, which is characterized, for example, by high blood pressure and signs of organ stress. And it can progress rapidly and lead to very severe complications if it's not detected early enough. So PLGF and SFLT1 are biomarkers which are commonly measured as a ratio to help evaluate the risk of preeclampsia. And in this condition, the balance between these two analytes actually shifts. So SFLT1 levels increase and PLG levels decrease, which is a sign of disruption of the normal placental function. A high SFLT1 PLGF ratio can indicate placental dysfunction even before clinical symptoms appear, which then makes it a very valuable tool for early diagnostics of preeclampsia. And this autumn, we will introduce antibodies for both of these analytes to support assay development in this very important area. We also have new developments on the antigen side. So we have very recent additions to our portfolio, which include recombinant TSH and IGF-1, as well as native PAP-A, which has been sourced from serum. And later this year, we are planning on expanding this offering with additional recombinant antigens such as FSH, LH, and prolactin, along with native PAP-A, which is derived from placental blood. And if you are interested in testing some of our hormone antibodies, we are now offering these for free for evaluation. So you can, for example, go check out our webpage at medixbiochemica.com and order your free samples from there, or then just let us know after the webinar and we will be in contact about the samples that you would like to receive. And if there's something that you currently don't see in the list of free samples, you can also be in contact, and we can see what else we could, for example, offer. And then finally, we also offer a variety of biospecimens for hormone diagnostics. So beyond blood, sweat, and tears, we offer a variety of other biospecimens as well. And later this year, we will also have hormone-depleted plasma for different analyses. And we also do customization and consider aspects such as pregnancy and age for these base matrices and biospecimens, and offer analyte testing. And with that, I thank you, and back to you, Anthony.
Well, thank you both very much for your presentations and walking us through that fascinating research and data. Now, I know that we are a little bit out of time, but I do want to take some time and go through the questions that people have answered. But I do first have a quick and selfish ask, and that's for your feedback. Feedback is an absolute gift, and we take the input that you guys provide us and are trying to make these webinars as useful for you as possible. So please do take the time to follow the QR code on the screen, or I will share a link to a survey for you if that's the method that you prefer. And let's get into it. So I've got a couple questions here, and I'll kind of I'll try to decide on which one's the best to answer it. But if I'm not correct, then certainly correct me. I think this one is for you. This first one is for you, Professor. And somebody has asked, what are some of the latest trends in hormonal diagnostics for women's health, especially in the fields of fertility and menopause? So what are those latest trends?
So thank you, Anthony, for the question. I think we are going more into accuracy. I think for a long time we were thinking that maybe the FSH would be the best marker, and definitely it is there still. But I think AMH has little by little becoming more accurate, and of course we are nowadays talking a lot about premenopausal symptoms. So I think their FSH doesn't play that big of a role because it's not high yet, but still many women can be symptomatic when they are a little bit estrogen deprived, and of course stress has lots to play here as well, as many women at that time of life they have quite stressful life situations, so that also kind of pushes the estrogen effects down. So I think measuring AMH, I think it's more accurate, and then of course looking into the whole picture. So well, I think the testing is moving away maybe a little bit more towards AMH compared to FSH, I would say.
Great, thank you. Let's stay with you. There's another one, and it's what are some of the current, or where do current hormone tests fall short when it comes to diagnosing some of the things that you mentioned, like PCOS and menopause?
Well, I think we need to be aware of our testing, and of course, the fact that some of the levels are quite low, so you need to consider the platform or the antibodies, the companies who are offering. Of course, that's really important. But looking into the diagnostic algorithm, trying to also explore the biochemical part of the syndrome. For example, PCOS, you would need to do differential diagnostics, but also rely on your tests and your analysis that this is PCOS. And you know, kind of have the supporting diagnostics around that diagnosis. So I think there, you know, having kind of enough of information yourself to be able to make the diagnosis, but on the other hand, when you have enough of evidence, to have the courage to make the diagnosis. Of course, as I said, you know, these differential diagnostic is very important, and the fact that people are many times there are no CPs, and you need to figure out whether you would take them out, you know, out from these pills to be able to make the diagnosis. So I think having the right tools, having kind of enough of supportive elements in your tool pack, and then knowing what you are measuring, I think those are the key factors here.
Excellent. Yeah, it's kind of the difference between having data and having information. It's important to know it all.
Yeah, absolutely.
Okay, let's go over to you, Maria.
Mhm.
They said, let's see, can you provide any type of technical data on the performance of the antibodies you have beyond the pair recommendations that you mentioned earlier?
Yeah, very good question. So absolutely. So we conduct in-house testing for our antibodies, and we do have technical data available on their performance, for example, across different assay formats, as I showed for AMH. And this data includes sensitivity and compatibility and how these work in different assay formats. While assay performance can vary depending on the specific setup, and it may require further optimization, we do provide the performance data for many of our antibodies, including results with clinical samples. For example, for our reproductive hormone antibodies that we have been discussing today, we actually have a very detailed technical note available online that really nicely summarizes some of the key performance metrics that we have. So we'd be happy to share this and any additional data relevant to your needs. So you can just drop a comment in the chat if you'd like us to send this technical note over to you, or you can go to our website and find the technical note under resources tab as well.
Great, thanks. Here's one that I'm particularly interested to hear the answer for, and Professor, somebody asked, so in the world of AI and machine learning, how help? Let me start over. I'm fumbling over my own words. How could AI and machine learning help improve how we interpret hormonal diagnostic tests?
No, that's a brilliant question. So I think there is a lot of potential. I think we have in our hands so many different analytes that sometimes it's difficult to kind of you know, notice it all, or remember the cutoffs, or as you just mentioned before, you know, diagnostics is about understanding your measurements, or what you've been measuring, and what are the thresholds, etc. So here I think AI would have a major role to be able to segregate from different, you know, bits and parts, you know, take everything together and make it as a kind of a pre-evaluate everything, and suggest maybe well, diagnosis or condition, or some sort of implications, how to interpret the data. I think that would be very, very helpful. And on the other hand, I think it also, on the other direction, it may want to suggest you something that, you know, maybe you want to assess this or that.
Yeah.
If you kind of missed, you know, the idea of what else do I need to make this puzzle complete. So I think there is a lot of potential. It might be that, you know, it's quicker, the development that we think, but definitely there is a potential. I'm personally looking into that, looking forward to that.
Great, that'll be exciting to keep up on. And to you, Maria, you mentioned the upcoming PIGF and SFLT1 antibodies. This is something that our current lab is looking into. Is there a possibility to get these for evaluation sooner?
Great to hear that you are interested in these upcoming products. We are definitely equally excited about this launch of PLGF and SFLT1 as well. So short answer, yes, we can certainly discuss the possibility of providing early evaluation samples. I can coordinate, for example, with your local sales representative, so we can then follow up directly with you. And as mentioned, the official launch of these products will be sometime during autumn, but we are, of course, happy to hear from also others who may be interested in early access. So please feel free to reach out directly or again, use the chat to let us know that you are curious about these antibodies, and we'll be sure to get in touch with you.
Great, thanks so much. And we'll stay with you for one last one, and I know this is one that's a topic close to your heart. Just curious, what are some of the concrete things you're doing at Medix Biochemica to be more sustainable?
Okay, yeah. Well, this is a really, really good general question. So sustainability is really something that we are actively focusing on at Medix Biochemica, both in our work and also on the manufacturing side. So we focus on high product quality and safety, for example, but we also take steps to reduce our carbon footprint. Then our supply chain is really held to a high environmental and social standards as well. And we also offer animal-free and recombinant production options for our products. And for example, last year we also received the EcoVadis silver rating, which then places Medix Biochemica above almost 90% of the companies assessed for their sustainability practices. So it's really something that we are proud of and are always working on improving.
That's great. And with that, I think we'll close up. So a very warm thank you to both of you for taking us through this exciting information. And thank you for all who were listened to us and stayed on. And for those who had to jump off a bit earlier, we will follow up with the slides and with the link to view this at a later date as well. And thank you for all the feedback for the first question and for the last question. And with that, we will wish you a good rest of your day and thank you all. See you next time.
Thank you, everybody.
Thank you.